Then it's an honor and pleasure to ask Professor Wollensak on his talk. On his talk, CXL in Lasik.
Уважаемое президиум, уважаемые дамы и господа. I will talk today about cross-linking and Lasik, and there are two major applications, as we will see later on. Iatrogenic post-Lasik ectasia is a fact, as can be seen in this example. Here you have the early topography post-op and 3 years later, and then you see the iatrogenic ectasia. And statistically, it's known to occur in 0.04 to 0.6% of patients after Lasik. And the other thing is that there is regression of the Lasik effect in up to 4 to 6%. That's also something that you don't want. So here also cross-linking might be an option. To assess the risk for these problems, Randleman has set up a score to have a quantitative score number that allows you to tell the patient how large the risk is for iatrogenic ectasia or regression. And as you can see here on top, there are 5 parameters that are taken into consideration, and there are basically 5 degrees of it. And so, for example, it's topography, the residual bed, stromal bed thickness, what is that's under the flap and after the ablation, the age, the corneal thickness. And as you can see, if the score that you get with these 5 parameters is higher than 2, then you get already a moderate risk, and you should proceed with caution. So there it's already dangerous or risky. And with more than 4, with a score of higher than 4, it's a very high risk, and usually you should not perform Lasik. So these are the Randleman scores, but there's also another risk factor, and that's the flap thickness, because the flap does not contribute to the biomechanical stability anymore after the treatment. It's very loose and does not contribute. And with the mechanical microkeratomes, you can get irregular and also deep flaps down to, for example, here 270 micrometers. Whereas with the new modern femtolasers, usually you can create very regular and flat ultra-thin flaps of only 100 microns. So then the remaining stromal tissue is stronger, because, as I said, the flap is basically lost for the biomechanical stability. So now I will talk about the 2 big applications. The one is prophylactic cross-linking, the other one is post-hoc cross-linking after ectasia has already occurred. So the prophylactic cross-linking is the new thing. It's in the media and it's also in the market, a big business, and usually it's called Lasik Extra, Superficial Interface CXL, In situ CXL, or CXL Plus. And it's done together with the Lasik procedure, and its aim is to stabilize the refractive results, to prevent regression, and also to prevent post-Lasik ectasia. And the method is based on earlier results of so-called accelerated cross-linking, AXL, and cross-linking using the femtolaser-created pocket. So this is basically a combination of these 2 new approaches. Here I have listed up the steps that are taken in the Lasik Extra procedure. it's done after the Lasik treatment, but right after it. And then you simply lift the Lasik flap, you apply riboflavin solution for 1 to 1.5 minutes. Then the solution is rinsed off, the flap stretched out again, and usually using CXL parameters, the UVA radiation also only takes 60 to 1 to 2 minutes, with, however, very high irradiances ranging from 9 to 30 milliwatts per square centimeter, whereas in normal CXL it's 3 milliwatts. And the total dose that is reached is often lower than the one with standard crosslinking. Standard crosslinking has 5.4 joule, and here with this method it's often lower. And post-op, you apply a bandage contact lens and use antibiotics and steroids like always. Here you can also see this on this scheme. Here basically the Lasik procedure with the flap lifting and the excimer laser ablation. And then on the right, the Lasik extra, where you apply the riboflavin drops, and then you wait for 1 to 2 minutes, and then you irradiate for 1 to 2 minutes with a high irradiance. Kanalopoulos has checked this procedure biomechanically in biomechanical in vitro measurements of human cornea, and he found an increase in biomechanical stability using this Lasik extra procedure by 129%, which sounds good, but in fact that's only 1/3 of standard CXL, which is where the increase is 328%. So this reduction of the overall cross-linking efficacy is probably due to first the reduction of UVA transmittance by the epithelium, which has been measured, and is about 20%, because with this Lasik extra procedure you do not remove the epithelium. It's an epi-on technique. And also the cross-linking effect only takes place under the flap, because the flap itself is not cross-linked, and even if it were, it would have no effect. So actually also the UVA is not only reduced by the epithelium, but also by the stroma of the flap. And the third point might be that the oxygen supply is reduced by the epithelium. Usually you need oxygen for an effective cross-linking process. And also the riboflavin impregnation time is short, only 90 seconds. Usually it's 15 minutes. So the concentration of riboflavin is low, of course. There have already been a number of publications on Lasik extra studies with mostly myopic Lasik, and a maximum follow-up of up to 4.6 years. And one thing is good, they did not find any side effects, except maybe some temporary faint haze or epithelial erosions, transient epithelial erosions. But still, it's hard to prove that there is an effect, because statistically you would need at least 10,000 patients to compare with and without the cross-linking to decide if there's really a protective effect against regression and ectasia. There have also been performed OCT hydrogenically active, but the depth below the flap is reasonably deep for the effect. So it makes sense to perform standard cross-linking in iatrogenic ectasia. And there have been many studies already been performed, and mostly they were successful with a few single cases with treatment failure. And here, for example, you can see a successful case by Hafesi, where there was preoperative iatrogenic ectasia, and after treatment, it returned to better diopter very quickly. And here in the study by Reiskop, you have the successful case where it also was reduced, ectasia was reduced after cross-linking, but there was also an unsuccessful case with continued ectasia even after cross-linking. So standard cross-linking for iatrogenic ectasia makes sense, but there is a treatment failure in extreme cases, so there's no guarantee for success. You also still have the normal risks with cross-linking, like infection scarring or transient haze or endothelial damage or even perforation. So cross-linking is mainly in the anterior 2/3 of the cornea, and it's therefore, because of the flap, there's still a reduced effect of cross-linking in post-LASIK ectasia compared to cross-linking in keratoconus, where there's no flap, of course. The risks of cross-linking can probably be accepted because keratoplasty is the main alternative anyway only. And I think cross-linking in iatrogenic ectasia is always worth a try, but it does not work in extreme cases. Again, long-term trials are needed with at least 10-year duration. And again, like with the first method, LASIK extra, I also would like to point out that it could be possible to increase the effect by lifting the flap before cross-linking. But of course, then there's a higher risk for the endothelium. So if I take all these methods together, the LASIK extra, which is a prophylactic treatment, and the cross-linking after the ectasia has already occurred, I would say cross-linking is a new and promising tool for prophylactic and post-hoc treatments of LASIK-related ectasia. However, long-term prospective trials are needed, and the overall biomechanical effect is at least only 1/3 of the standard cross-linking, and the efficacy of the treatment could be increased in both cases with both LASIK extra and post-hoc treatment if the flap would be lifted before the actual cross-linking takes place. I thank you for your attention. Thank you.
Thank you very much. The paper is open for discussion, please. Microphone.
You hear me?
Right. Now, when you in the femtosecond pocket, when you use the 0.1% riboflavin concentration, 0.1%, what's the actual concentration in the stroma? The second question is, the higher concentration will help the efficacy and also the safety.
Well, I didn't understand the second question. The first question was about the concentration of riboflavin in LASIK extra, or when?
The concentration inside the stroma.
With which method? LASIK extra or standard cross-linking after ectasia? There are two methods here.
The femtosecond one. In the pocket, femtosecond pocket.
In the what? In the LASIK extra or not?
Under the flap. Your first case, you presented. After you flap the flap, after the flap, okay, inside the flap.
Inside the flap,
yes,
well,
inside the flap.
Inside the flap, the concentration depends on the method. Kanellopoulos, for example, tries to avoid any riboflavin in the flap, so he rolls off the flap very meticulously and tries to avoid any contact with the riboflavin, and he rinses off the riboflavin excessively, so that even if he puts the flap back on, there will be no riboflavin or almost no riboflavin in the flap. But there are other people and also companies that tell the doctors to try to get also the riboflavin into the flap, but which doesn't make much sense for me, because the flap does not help biomechanically anymore, and if you put in riboflavin into the flap, only the UV irradiance will be reduced in the deeper layers, because it will already be absorbed in the flap. So if you ask me, I would try to keep the flap without riboflavin.
No, my question is, what's estimated concentration inside the stroma?
The stroma, not the flap, you mean?
Yeah, inside the stroma.
Inside the stroma.
Let us say you use a 0.1% riboflavin. Okay, you use a 0.1% riboflavin, then what will be the actual concentration in the stroma?
Yeah, it also depends on the time of impregnation. I said it was 1 to 2 minutes, and but I think it's not the problem. They don't need much riboflavin for an irradiation time of 1 to 3 minutes. I don't think this is the problem. But I haven't measured it for the different methods. I mean, some use different irradiances. It's and the impregnation times. It's they have to measure it themselves. It's not my problem. But I don't think that this is a problem. The amount of riboflavin is not the problem. I don't think so.
Yeah, do you have comments on the endothelial damage threshold? Your paper in 2003 reported it's about 0.63 joule centimeter square, but there are more recent paper published. They say could be 8 times bigger. What's your comments?
Yeah, my comment about this study from Belgium is that I don't believe it. I have seen reports about dramatic endothelial damage if you defocus during the irradiation, and all the endothelium can be burned off with a standard cross-linking if you do not keep the right distance. And even the same group that has published these new results about lower or higher thresholds for endothelial damage has reported such complications. So I don't believe in these results.
All right, thank you.
Other questions, please? Please.
Спасибо за доклад. У меня такой вопрос. Проведение кросслинкинга в случаях с кератоэктазией мы получаем изменение силы роговицы, мы меняем рефракцию. Поскольку Lasik является рефракционной процедурой, и у меня такой вопрос, что комбинируя Lasik и кросслинкинг, все-таки мы ожидаем от Lasik рефракционный результат. Насколько предсказуем этот рефракционный результат, комбинирует эти две процедуры?
As I've heard from other groups, there's no significant effect. You can still use the same ablation rate of the laser, and you get the same refractive results, whether you apply riboflavin or not, whether you apply cross-linking or not. It's the same nomograms. It's usually does not really change. There's one group, Campik, in Munich, they claimed some years ago that there's a difference, but I've talked to people who've done this a lot, and they say it's not really, you don't have to change the ablation or something to get the same refractive results if you use Lasik extra.
Any other questions?
Спасибо.
If you apply the dye into the stromal bed, is there not a higher risk for the ultraviolet light to penetrate into the lens and to damage lens and retina?
You mean the femtopocket technique? When you apply it into a femtopocket? Well, usually it does not, the concentration of riboflavin is not higher in the endothelium. The irradiation takes place from outside. The femto technique was created to prevent the removal of epithelium, to prevent pain. So that's why the riboflavin is injected right into the place where it should work, but it does not really change much the safety profile or the irradiation damage. It's the time has been adapted to in such a way that it's very similar to standard CXL. So the safety risks are the same like the standard CXL, but the efficacy, biomechanical efficacy, is less, is somewhat less.
Any other question? Okay, thank you. On behalf of my colleagues here, it is an honor for me to thank the organizers for giving us the honor to be here, the speakers for the talks, and you for your attendance. The session is closed.